Welcome, everyone. I'm Tita Sonrat from the Integrated Care Resource Center, or ICRC. Thank you for joining us today for this introductory Working with Medicare webinar, which will provide an introduction to state contracting with dual eligible special needs plans, or DSIPs. Slide 2, please. Before we get started, I'd like to quickly go over a few logistics. For those of you joining by phone, you can view the slides by logging into Zoom. You can find the directions for doing that in the calendar appointment for today's webinar, which you should have received via email after registering. We'll be recording this call so you can revisit today's presentation or share the recording with colleagues who are unable to join. We will send you a link to that recording in the slide deck soon, and we will also post the slides and recordings on the Integrated Care Resource Center website. To eliminate background noise, all attendees' phone lines will be muted during today's presentation. We will have a Q&A segment at the end of today's webinar, but we'll keep the phone lines muted. So we ask you to submit questions through the Q&A icon at the bottom of your screen. You can submit your questions at any point during the webinar. If you'd like to use the closed captioning feature, click on the More Options button in the Zoom toolbar at the bottom of the screen and select the Captions button. You're also able to edit the caption settings to adjust the text size by going to the Subtitle Settings option. Next slide, please. This webinar is part of a series of ICRC resources for states on Medicare and dually eligible individuals. This series is designed for all states interested in improving coordination of Medicare and Medicaid benefits for dually eligible individuals. You can find recordings and slides from past Working with Medicare webinars, as well as written tools and e-alerts on Medicare-related issues that are important to states on the ICRC website at integratedcareresourcecenter.com. Next slide, please. Now I'll talk about the state's roles in advancing integrated care. State Medicaid agencies have an important role to play in promoting greater alignment between Medicare and Medicaid coverage and process for the growing number of dually eligible individuals enrolled in DSIPs. Because DSIPs must hold contracts with both CMS and the state that they operate in, state Medicaid agencies can use their contracts with DSIPs to influence the level of Medicaid benefit integration delivered in DSIPs, as well as how care is coordinated for DSIP enrollees. This opportunity is increasingly important as nearly half of dually eligible individuals nationwide are enrolled in DSIPs as a result of tremendous growth in DSIP enrollment in recent years. Next slide, please. Now I'll walk through the agenda for today's webinar. First, I will introduce our presenters. Next, we will provide a very brief introduction to dually eligible individuals and a more detailed overview of DSIPs. Then we will share basic DSIP contracting principles and cover what is new in DSIP contracting for 2027 and 2030. Finally, we will wrap up with questions and answers. Slide 6, please. During today's webinar, we will hear from 4 ICRC staff members. I'm Tita Sonrat from Mathematica, and I will present the first segment of today's webinar. Then Ahimsa Govender from Mathematica will present the second segment, followed by Gretchen Bell from the Center for Healthcare Strategies. And finally, Kat Fernandez from Mathematica will wrap up. Next slide, please. Dually eligible individuals are a high-need, high-cost population, especially compared with people who only have Medicare or Medicaid benefits. For example, 63% of dually eligible individuals have 3 or more chronic conditions. Additionally, 64% of full benefit dually eligible individuals have a behavioral health diagnosis, and 37% use Medicaid-funded long-term services and supports. Dually eligible individuals also account for a disproportionate share of Medicare and Medicaid spending. For example, dually eligible individuals represent 19% of Medicare enrollment, but account for 35% of Medicare spending. Similarly, for Medicaid, dually eligible individuals represent 13% of Medicaid enrollment, but account for 27% of Medicaid program costs. Next slide, please. Dually eligible individuals can choose how they will receive their Medicare coverage. The 2 primary Medicare coverage options include receiving coverage through original fee-for-service Medicare, often with Part D plans to cover prescription drugs, or enrolling in Medicare Advantage or MA plan. Under the Medicare Advantage program, dually eligible individuals can choose from a variety of different MA plan options, including special needs plans, or SNPs. SNPs include chronic condition SNPs, or CSNPs, institutional SNPs, or ISNPs, and DSNPs. CSNPs are designed for people with specific chronic conditions, and ISNPs are designed for people who reside in nursing facilities or other institutions, or who reside in the community but need the level of care provided in these kinds of institutions. DSNPs, the focus of today's webinar, are Medicare Advantage plans that are designed specifically for people who are dually eligible for Medicare and Medicaid. All DSNPs must at least coordinate Medicaid benefits for their enrollees. However, there are 3 types of DSNPs that can provide varying levels of integration for Medicare and Medicaid benefits. Coordination-only DSNPs, or COSNPs, are less integrated plans, while highly integrated DSNPs, or HIDE-SNPs, and fully integrated DSNPs, or FIDE-SNPs, both of which here are shaded in green, require higher levels of integration and greater alignment of Medicare and Medicaid processes. In addition to DSNPs, some states have used 2 other types of programs to integrate Medicare and Medicaid benefits for dually eligible individuals. 33 states and DC have programs of all-inclusive care for the elderly, or PACE, which provide a comprehensive set of Medicare and Medicaid benefits to people above age 55 who need a nursing facility level of care but live in the community. 8 states are also in the process of winding down enrollment in Medicare and Medicaid plans, or MMPs, that operated as part of Financial Alignment Initiative demonstrations. Effective January 1st, 2026, these states will transition to using integrated DSNPs instead of MMPs. Next slide, please. This pie chart shows the Medicare coverage choices that dually eligible individuals made in 2024. In late 2024, 45% of dually eligible individuals in the United States were enrolled in DSNPs, which is represented by the striped dark blue section. 19% were enrolled in other types of Medicare Advantage plans, including CSNPs and ISNPs, which is shown in the green section. 34% were in fee-for-service Medicare, which is represented by the light blue dotted section. And small percentages were enrolled in MMPs and PACE organizations, which are shown in striped black and white and gray respectively. Next slide, please. This map of the United States shows the approximate proportion of dually eligible individuals enrolled in DSNPs in each state in late 2024. The map on this slide uses 4 color categories. The blue and white stripe shading indicates states with 0 enrollment in DSNPs. Light blue represents states with 1 to 25% enrollment in DSNPs. Dotted green shows states with 26 to 49% enrollment in DSNPs, and dark blue indicates states where 50 or more percent of dually eligible individuals are enrolled in DSNPs. In 14 states and Puerto Rico, more than 50% of dually eligible individuals are enrolled in DSNPs, and in 39 states, the District of Columbia and Puerto Rico, at least 25% of dually eligible individuals are enrolled in DSNPs. Alaska, Illinois, New Hampshire, and Vermont do not currently have DSNPs, but Illinois will be contracting with DSNPs in 2026 as the state converts its Financial Alignment Initiative demonstration to a DSNP model. Thank you, and I will now pass it over to Ahimsa.
Thank you, Tita. Hello, everyone. In this section, we will discuss DSNP requirements, describe how DSNPs differ from other Medicare Advantage plans, and cover the levels of DSNP integration. Next slide, please. As Tita noted previously, DSNPs are a type of Medicare Advantage plan that only enroll dually eligible individuals. DSNP requirements have evolved over time, with CMS focusing on promoting greater coverage alignment and enhancing and clarifying DSNP requirements for care coordination in recent rulemaking. Congress created DSNPs through the Medicare Modernization Act in 2003, and DSNPs began operating in 2006. Since 2013, DSNPs have been required to have contracts with state Medicaid agencies in addition to having a contract with CMS to provide Medicare benefits. This provides states with the opportunity to define specific requirements for DSNPs operating within their state so that they can better integrate care for their dually eligible populations. The Bipartisan Budget Act of 2018 permanently authorized DSNPs, and shortly thereafter, in 2019, CMS issued new definitions and requirements for FIDE-SNPs, HIDE-SNPs, and CO-DSNPs. Between 2022 and 2025, CMS released additional rules for DSNPs that aim to continue to improve the experiences of DSNP enrollees and further the extent to which DSNPs offer coordination and/or integration of Medicare and Medicaid benefits. We'll talk more about these requirements in the next several slides. Next slide, please. DSNPs and other types of Medicare Advantage plans have some of the same features. For example, they all must hold a contract with CMS to provide Medicare benefits and may offer supplemental benefits such as dental, vision, hearing, and transportation. However, because DSNPs are specifically designed for duly eligible individuals, they must meet certain requirements that go beyond the requirements of other Medicare Advantage plans to address the needs of this population. For example, DSNPs must hold a contract with the state Medicaid agency, and that contract must include certain minimum requirements, which we'll discuss shortly. They also tailor their benefits specifically to meet the needs of the duly eligible population. They must also coordinate and/or integrate delivery of Medicare and Medicaid benefits. Additionally, some DSNPs cover Medicaid benefits for their enrollees. And finally, all DSNPs must have a model of care, or MOC, that is approved by the National Committee for Quality Assurance and describes how the DSNP will coordinate care and meet the needs of its enrollees. Next slide, please. Continuing our discussion of DSNP requirements that do not apply to regular Medicare Advantage plans, DSNPs must also establish and maintain at least one enrollee advisory committee in each state where the plan operates. They must also collect information about enrollees' transportation, housing, and food security needs during health risk assessments, or HRAs. Starting in 2026, DSNPs must begin to complete HRAs within 90 days before or after enrollment, conduct at least 3 non-automated HRA outreach attempts, and complete an integrated care plan for each enrollee within 90 days of HRA completion or within 90 days of enrollment. In addition, applicable integrated plans, or AIPs, must complete a single integrated HRA for each enrollee and issue integrated enrollee ID cards starting in 2027. My colleague Gretchen will discuss AIPs during the next segment of the webinar. Next slide, please. As I noted in the last couple of slides, DSNPs are required to provide certain care coordination services for enrollees that are not required in non-SNP Medicare Advantage plans. On this slide, I will spend a few minutes taking a deeper dive into those DSNP care coordination requirements. First, DSNPs must assess their enrollees' physical, psychosocial, and functional needs through an initial HRA, which is repeated annually using a plan-identified assessment tool. A plan's HRA assessment tool must incorporate questions about enrollees' housing, transportation, and food security needs. DSNPs must complete initial HRAs within 90 days of enrollment. DSNPs must also develop and implement individualized care plans for each enrollee and use interdisciplinary care teams, or ICTs, to address enrollees' health and functional needs. ICTs must include a team of providers that have expertise and training that are appropriate for the DSNPs population. To assure an effective care management structure for their enrollees, DSNPs must develop and use a model of care, or MOC. The MOC is the basis for the DSNPs care coordination processes and must be reviewed and approved by the National Committee of Quality Assurance. Lastly, DSNPs must coordinate Medicaid benefits in addition to Medicare benefits for all enrollees, including helping them request service authorizations and file Medicaid-related grievances and appeals. Next slide, please. Now that we covered a variety of DSNP requirements, I will describe the various levels of DSNP integration. First, CO DSNPs are the basic level of DSNP. These DSNPs must at least coordinate Medicaid benefits, and they must notify the state or the state's designee of hospital or skilled nursing facility admissions for a group of designated high-risk, full-benefit dually eligible enrollees. While some COD SNPs in some states may cover Medicaid benefits, CMS does not require these DSNPs to cover any particular Medicaid benefits. In those cases, the state Medicaid agency has chosen to incorporate those requirements into its contracts with the DSNPs. Next, we have HIDE SNPs, which must cover Medicaid behavioral health benefits and/or long-term services and supports, either through the DSNP or an affiliated Medicaid managed care plan that is offered by the same parent company as the DSNP. To qualify as a HIDE SNP, the parent company's Medicaid contract with the state needs to cover the entire service area of the DSNP. FIDE SNPs offer the highest level of integration. To qualify as a FIDE SNP, the DSNP must operate with exclusively aligned enrollment and cover a comprehensive set of Medicaid services, including Medicaid primary and acute care services, Medicare cost sharing, home health, durable medical equipment, supplies and appliances, behavioral health services, and LTSS, including at least 180 days of nursing facility coverage. FIDE SNPs must also use specialized care management and provider network methods to coordinate care for high-risk enrollees, and the entity contracted to cover Medicaid benefits must be the same legal entity that it holds the DSNP contract with CMS. And finally, a FIDE SNP's capitated contract with the state Medicaid agency must cover the entire service area of the DSNP. If you'd like more information on the different levels of DSNP integration, you can review the ICRC tip sheet linked at the bottom of the slide. Next slide, please. I mentioned that FIDE SNPs must operate with exclusively aligned enrollment, so I want to take a moment to define that term. Exclusively aligned enrollment, or EAE, occurs when the state contract limits enrollment in the DSNP to full benefit dually eligible individuals who receive their Medicaid benefits from the DSNP or an affiliated Medicaid managed care plan offered by the same parent company as the DSNP. EAE facilitates use of several strategies to integrate coverage and navigation of Medicare and Medicaid benefits, such as fully integrated enrollee materials, single ID cards, and unified appeal and grievance processes. Next slide, please. Before we move on to the next section of the presentation, I want to highlight a few key takeaways from this section. First, DSNPs are Medicare Advantage plans that only enroll dually eligible individuals. Second, DSNPs differ from other Medicare Advantage plans in key ways. For example, DSNPs must have contracts with state Medicaid agencies and must collect information about enrollees' transportation, housing, and food security needs during HRAs. Third, DSNP requirements have changed over time, with CMS focusing on promoting coverage alignment and greater coordination of care in recent rulemaking. And finally, DSNPs vary in their level of integration, with FIDE SNPs offering maximum integration of Medicare and Medicaid coverage for dually eligible individuals. I will now pass it on to my colleague Gretchen to discuss basic DSNP contracting principles.
Thank you, Ahimsa. Now that Ahimsa has provided an introduction to DSNPs, I will review the basic DSNP contracting principles that state staff should keep in mind when developing and updating contracts with DSNPs. Slide 20, please. In addition to contracts with CMS, DSNPs must have state Medicaid agency contracts, or SMACs, with each state in which they operate. These SMACs must include minimum contract elements that we will cover shortly, but it is also important to note that states may include additional state-specific requirements in these contracts to improve administrative, clinical, and financial integration for enrollees. Please also keep in mind that states can choose not to contract with DSNPs at all, and that states have the authority to choose whether to contract with particular DSNPs as well. Slide 21, please. Some states use their contracts with DSNPs to require DSNPs to cover Medicaid benefits for DSNP enrollees, either by paying DSNPs directly to cover these benefits through the DSNP, or by aligning DSNPs with affiliated Medicaid managed care plans that are offered by the same parent company as the DSNP. The states that do this have required DSNPs to cover a range of benefits. For example, some states pay DSNPs capitated rates just to cover Medicare cost sharing amounts, without having DSNPs cover any other Medicaid benefits. In other states, DSNPs cover some Medicaid benefits, but not others. In several states, DSNPs or their affiliated Medicaid managed care plans cover substantially all Medicaid benefits, creating an opportunity for maximum integration of Medicare and Medicaid coverage. Slide 22, please. Federal rules require all DSNPs to have at least a certain minimum elements in their SMACs with states. These minimum elements include the Medicare Advantage's organization, responsibility to coordinate the delivery of Medicaid benefits, the categories of duly eligible individuals eligible to enroll in DSNP, and the Medicaid benefits covered by the DSNP. In addition, SMACs must detail the cost-sharing protections afforded to DSNP enrollees, how the state will identify and share information on Medicaid provider participation with DSNP, how the DSNP will verify potential enrollees' eligibility for Medicaid, the DSNP service area, and its contract period. States can find sample SMAC language for each of these minimum elements in the ICRC tools, for which we've provided a link in the call-out box on this slide. Slide 23, please. In addition to the minimum requirements mentioned in the previous slide, CODSNPs must adhere to specific notification requirements intended to support transitions across settings of care. CODSNPs that enroll at least some full benefit duly eligible individuals must notify the state and/or its designee of Medicare hospital and skilled nursing facility admissions for at least one group of high-risk, full benefit duly eligible DSNP enrollees identified by the state. In addition to identifying the high-risk group of enrollees for whom the DSNP must send these admission notifications, states that contract with these DSNPs must also establish how the DSNP will provide these notifications to the state Medicaid agency or the state's designee. The state's SMAC must specify the high-risk group, the receiving entity, and the method and timing of the notifications. For CODSNPs that authorize another entity to perform this notification, the SMAC must also indicate that the DSNP retains responsibility for complying with this requirement. As a reminder, the requirement applies to CODSNPs that enroll at least some full benefit duly eligible individuals. For DSNPs that only enroll partial benefit duly eligible individuals, this notification requirement does not apply if the DSNP operates under the same parent organization and in the same service area as the DSNP that enrolls only full benefit duly eligible individuals that meets these notification requirements. States can find more about this notification requirement for CODSNPs in the ICRC link provided in the call-out box on this slide. Slide 24, please. Now let's take a closer look at a couple of the minimum requirements we just reviewed to provide some additional context about these elements. First, let's start with the contract element number 1, which is the Medicare Advantage organization's responsibility to coordinate the delivery of Medicaid benefits. In practice, this means that the SMAC must clearly describe the DSNP's responsibility to coordinate the delivery of Medicaid benefits, including mechanisms for coordinating Medicaid services covered under Medicaid fee-for-service by the Medicare Advantage organization itself, or by other Medicaid plans available in the state. For example, a state can require a D-SNP to educate its enrollees about Medicaid benefits for which they may qualify, to help enrollees access those benefits, and to assist them with filing appeals and grievances related to Medicaid benefits. On this slide, we've also provided sample contract language that states can consider using to meet this requirement. Slide 25, please. Next, let's take a closer look at contract element number 7, which requires details on the D-SNP's service area to be included in the SMAC. In practice, this means the SMAC must clearly identify the counties in which the D-SNP is allowed to market and enroll people. The counties listed in the SMAC must be consistent with the service area that the D-SNP specifies in the CMS Health Plan Management System, or HPMS, when submitting its bid to CMS. And if a D-SNP wishes to qualify as a HIDE-SNP or a FIDE-SNP, the service area of the Medicaid Managed Care Plan must encompass the entire service area of the D-SNP. Like the previous slide, this slide also includes some sample contract language that states can consider using for this element, including language that can address scenarios in which a SMAC covers multiple D-SNP plan benefit packages. ICRC's SMAC sample language tool also includes an example table that shows how states can identify which categories of duly eligible individuals and service areas are covered under each plan benefit package included in a SMAC. Slide 26, please. SMACs for HIDE-SNPs must include additional elements beyond the minimum requirements. First, to obtain a HIDE-SNP designation from CMS, a D-SNP SMAC must specify the entity that is responsible for covering Medicaid benefits, which could be the HIDE-SNP, the HIDE-SNP's parent company, or another entity owned and controlled by the HIDE-SNP's parent organization. Second, the SMAC must specify the Medicaid LTSS and/or Medicaid Behavioral Health Services covered by the HIDE-SNP or its affiliated Medicaid Managed Care Plan. Third, the SMAC must include the service area of the HIDE-SNP and the entity responsible for covering Medicaid benefits. As a reminder, the HIDE-SNP's capitated contract with the state Medicaid agency for coverage of Medicaid benefits must cover the entire service area of the D-SNP. Beginning in 2027, the D-SNPs upload their SMACs into HPMS for CMS review. They will need to upload a copy of the relevant Medicaid Managed Care contract, if applicable. D-SNPs that will qualify as HIDE-SNPs may show information about the entity holding the Medicaid contract and the Medicaid contract service area via the uploaded Medicaid contract rather than in the SMAC. Slide 27, please. Similarly, a D-SNP SMAC must include additional information for the D-SNP to obtain FIDE-SNP designation from CMS. To start, the SMAC must include the name of the single entity that holds the Medicare Advantage contract with CMS and the Medicaid Managed Care contract with the state, as well as the Medicaid benefits covered by the D-SNP or its affiliated Medicaid Managed Care Plan. In addition, the FIDE-SNP SMAC must include requirements that the FIDE-SNP must coordinate the delivery of covered Medicare and Medicaid services using aligned care management and specialty care network methods for high-risk enrollees. Additionally, they must employ policies and procedures to coordinate or integrate certain aspects of the enrollee experience. Finally, the SMAC must include the service areas covered by the FIDE-SNP and the entity responsible for coverage of Medicaid benefits, a requirement that the FIDE-SNP must operate with exclusively aligned enrollment, and a requirement that the FIDE-SNP must use a unified appeals and grievances procedure described in federal regulations. The same note about uploading Medicaid contracts into HPMS in 2027 applies to the FIDE-SNP in addition to the HIDE-SNPs. Slide 28, please. Next, we'll cover qualifications for AIPs. AIPs are DSNPs that are FIDE-SNPs or HIDE-SNPs that operate with exclusively aligned enrollment, or a CO DSNP that operates with exclusively aligned enrollment and covers certain Medicaid benefits. Those benefits must include Medicaid primary and acute care, Medicare cost sharing, and at least one of Medicaid coverage of home health services, medical supplies, equipment and appliances, and/or nursing facility services. AIPs are also required to use unified appeals and grievances procedures. When states execute SMACs with DSNPs that will qualify as AIPs, those SMACs should indicate that the DSNPs must operate with exclusively aligned enrollment and use the unified appeals and grievance process specified in federal regulations, in addition to describing the Medicaid benefits that will be covered by the DSNP or its affiliated Medicaid managed care plan. Slide 29, please. When executing contracts with DSNPs, it is important for states to be aware of key dates in the Medicare Advantage contracting process. ICRC has developed a tool highlighting these dates for states, which can be found at the link at the bottom of this slide. We've also provided a high-level overview of some of these key dates here. For example, new Medicare Advantage contracts always run on a calendar year, so the effective date for the contract and new plan enrollments is always January 1. When a Medicare Advantage organization wants to establish a new plan or expand its service area, it must also submit a notice of intent to apply to CMS between November and February of the years preceding the intended contract year. And all DSNPs must submit their executed SMACs in their intended state of operation to CMS for review in July of the year preceding the intended contract year. The notice of intent to apply and SMAC submission dates are particularly important for state officials to be aware of when they are developing their DSNP requirements or planning for a procurement of affiliated Medicaid managed care plans. Slide 30, please. As reminders, here are a few key takeaways from this section of today's presentation. First, states should be aware of minimum contract requirements for all DSNPs, such as coordination of Medicaid benefits and the categories of duly eligible individuals eligible to enroll in the DSNP. Second, states that contract with HIDE-SNPs, FIDE-SNPs, and AIPs should understand additional contract requirements for these plans, such as coverage of Medicaid benefits, and for AIPs specifically, the requirement that the DSNP use unified appeals and grievances procedures. Third, states have broad flexibility to add elements to their SMACs that can support their integration goals. Fourth, states should track key Medicare Advantage dates as they develop and issue state Medicaid agency contracts in partnership with DSNPs, such as the deadlines for DSNPs to submit SMACs to CMS. I will now pass it on to my colleague, Kat, who will describe new rules for DSNPs in the coming years. Slide 31, please.
And this is Erin from ICRC. Kat, if you're talking, I think you might be on mute. So just want to give you a chance to get that cleared up.
Thank you, Erin. Can everyone hear me?
Yes, now you're back. Thanks, Kat.
Thanks, Erin. And thank you, Gretchen. So in this section, I will discuss what's new in DSNP contracting for 2027 and 2030. Slide 32, please. Beginning in 2027, DSNPs that operate in overlapping service areas with Medicaid managed care organizations, or MCOs, that are operated by the same parent organization and enroll full benefit duly eligible individuals may only offer one DSNP for full benefit dually eligible individuals in the same service areas as the Medicaid managed care organization. There are limited exceptions to this rule. For example, if the state's SMAC differentiates DSNP enrollment by age group or aligns each DSNP with Medicaid eligibility or benefit design used in the state's Medicaid managed care program, the Medicare Advantage organization may offer one or more additional DSNPs for full benefit duly eligible individuals in the same service area, but only to match the group specified in the state contract. Additionally, if a parent organization offers an HMO DSNP and a PPO DSNP in the same service area as the Medicaid MCO, and both enroll full benefit duly eligible individuals, both plans can continue to operate, but only one will be allowed to enroll new enrollees. Slide 33, please. In 2027, the DSNPs affected by the new rule that I just described on the last slide will also only be allowed to enroll new individuals who are enrolled in or are in the process of enrolling in the affiliated Medicaid MCOs. This portion of the rule is aimed at creating greater alignment in Medicare and Medicaid coverage for enrollees in these DSNPs, and ultimately pushing them toward exclusively aligned enrollment, which they will have to achieve by 2030. Slide 34, please. Starting in 2026, all special needs plans, including DSNPs, must conduct an initial HRA within 90 days before or after the enrollee's effective date and develop an individualized care plan within 90 days of conducting the initial HRA or within 90 days after the effective date, whichever is later. Starting in 2027, AIPs must use integrated member ID cards that work for both Medicare and Medicaid benefits that conduct integrated HRAs for Medicare and Medicaid. Now I will pass it to Erin, who will facilitate the Q&A portion of this webinar. Slide 35, please.
Thank you, Kat, and thank you very much to all of our presenters in today's webinar. If you can go ahead and move to slide 36, please, Emily. I just want to give a quick reminder that to submit questions, you can click on the Q&A icon at the bottom of your screen to submit those questions through the question box. We're going to still have all attendees be automatically muted throughout the whole webinar. So we have to take all of our questions through the Q&A box. That's the only way that you can submit them, is to type them in there. But I will watch that box and try to answer as many questions, or we as a team will try to answer as many questions as we can with the remaining time that we have left for today's webinar. If we see somebody ask a question and we're not able to get to it today, we'll also do our best to follow up with you via email afterwards to make sure that your questions get answered. We do restrict these webinars to only folks who represent state Medicaid agencies. So I also want to let everybody in the room know that that is the audience that you're among, is other state Medicaid agency folks like yourselves, in case that's helpful context in sharing your questions. So I'm going to go ahead and dig in with a question that I had seen come through during the presentation. Tita, I believe this question is for you. It looks like this person was referring to slide 8. And Emily, if it's not too difficult for you, I wonder if you might be able to rotate back to slide 8. I know that's a while back in the presentation, so apologies. But on slide 8, this person was asking about why certain boxes were shaded in green. What does that mean? I wonder if you could take a minute to just re-explain what the green shading was for on this slide.
Yeah, of course. That's a great question. The green shaded plan types are HIDE SNPs, FIDE SNPs, PACE plans, and MMPs. These plans offer more integrated Medicare and Medicaid coverage for dually eligible individuals rather than other types of coverage arrangements, such as original fee-for-service Medicare and standard Medicare Advantage plans. So, for example, HIDE SNPs are Medicare Advantage plans that offer Medicaid coverage for LTSS and or behavioral health services. And FIDE SNPs are also Medicare Advantage plans, but they offer comprehensive coverage of several types of Medicaid benefits, including primary and acute care, Medicare cost sharing, behavioral health services, home health services, medical supplies, equipment and appliances, and LTSS, including at least 180 days of coverage for nursing facility services. And we have more details on these plan types on the ICRC website.
Thank you very much, Tita. And I had one question here for Ahimsa as well. And that is, are FIDE SNPs always more integrated than HIDE SNPs?
Thanks, Erin. So generally, FIDE SNPs offer the highest level of integration among DSNPs, but it is possible that a HIDE SNP could offer the same level of benefit integration as FIDE SNPs, but not meet the full FIDE SNP definition. So to put this into context and for an example, a HIDE SNP could offer the same Medicaid and Medicare benefit coverage as a FIDE SNP, but if the HIDE SNP does not offer all of the benefits under a single legal entity, which is important, it cannot qualify as a FIDE SNP. So as a result, I think we sometimes see states where most DSNPs are FIDE SNPs, but one or two DSNPs are HIDE SNPs. And often those HIDE SNPs are covering the same set of benefits as the FIDE SNPs. They just don't meet the legal entity requirement to qualify as a FIDE SNP. So examples of some states where this has occurred in 2025 include Hawaii, New Jersey, and Virginia.
Thank you, Ahimsa. And I see we have a question in the Q&A box about the what is the Code of Federal Regulations reference for the new rules for the integrated member ID cards in calendar year 2026. We are going to try to locate that, and we'll come back and share it with the group if we're able to find that during the call. If not, we'll be happy to follow up in the email that we send to registrants with the slides. We can share that that reference to the Code of Federal Regulations where those changes are for the new rules for 2026. I also see a question asking if there are specific CMS requirements or a particular template that DSNPs must use for their health risk assessments. And that's a really great question. Thank you for asking that. The answer is no. There's not a particular template or tool that CMS requires DSNPs to use for their health risk assessments. DSNPs do have to abide by the requirements in federal regulations, and the requirements for DSNP health risk assessments are at 42 CFR 422.101 F as in Frank. And I'll say that one more time. It's 42 CFR 422.101 F as in Frank. In that section, you'll find requirements related to the DSNP model of care, health risk assessments, and care coordination more broadly. And there are requirements about the specific sort of broad general topic areas that must be covered within the DSNP's health risk assessment, but there's not a requirement to use a specific tool for the assessment as a whole. The other thing to be aware of is that in recent years, CMS has added requirements to that section demanding that DSNPs incorporate into their HRAs specific questions related to members' transportation, food security, and housing needs. And when those additional requirements got added, CMS did put out guidance regarding where DSNPs must draw those specific questions from, the questions about particular social needs. Those questions, if the state doesn't require particular questions to be used, the DSNPs do have to choose from a set of standardized validated tools that CMS has listed in their subregulatory guidance to pull those 3 questions from. But as far as a template for the tool as a whole, there is not one of those. DSNPs can use whatever format or tool they want unless the state uses its contract to impose specific requirements related to the HRA. And thank you. One of our team members was able to find the specific Code of Federal Regulations references for the member ID cards. I'm going to go ahead and read that out now. I think I can also paste this in as a typed answer in the Q&A box. So I'm going to do that, but I don't know if everyone will be able to see that or not. So I'm going to go ahead and read it out loud just in case some of you can't see what I've just pasted into the Q&A box. So the Code of Regulation references where you can find the new requirements for member ID cards for 2026 are 42 CFR section 422.2267 E30 and then 423.2267 E32. Those are the sections 422.2267 and section 423.2267 are where you can find information about certain member materials for Medicare Advantage and Part D plans. And those subsections that I just referenced is where you can find the member ID card requirements specifically. So hopefully that is helpful. I've got another question here for Gretchen. Gretchen, you had mentioned that applicable integrated plans have to use unified appeal and grievance processes. Can you describe those processes again, please?
Yes, thanks, Erin. Great question. So unified appeal and grievance processes connect to the integrated benefit package offered by the DSNPs. So AIPs must offer an integrated plan level appeal and grievance pathway for all Medicare and Medicaid benefits other than prescription drugs. This unified process essentially resolves misalignments between what would have otherwise been separate Medicare and Medicaid plan level processes. So, for example, under a unified appeals process, the plan will only notify an enrollee that a benefit was denied if it was denied under both Medicare and Medicaid. If something was denied by Medicare but not Medicaid, the plan would simply cover the benefit rather than sending an enrollee a confusing pair of notices about the coverage. I'll say additionally, if a plan notifies an enrollee that an adverse coverage decision was made, there will be one single pathway the enrollee can use to appeal that decision. If the DSNP denies an enrollee's request for a service and the enrollee files an appeal with the plan has 30 days to make a decision about the appeal under the standard appeals process, or 72 hours to make a decision under the expedited process. As a side note, we have more information about these processes in the ICRC's Unified Appeals and grievances resources, which we provided in links in the slide deck from today's presentation. So you should be able to access those from the follow-up email.
Thank you, Gretchen. Thank you very much. I see our next question in the chat is from Kat's section about the new rules for 2027 and 2030. Emily, while we have Kat answer this question, I wonder if you could go back just a couple of slides here to slide 32, please. Thank you. So I think, and actually, you know what? Let's go to slide 33 because I realize this is about the second portion of this. So I think what the person asking the question is asking is for the DSNPs that will have to abide by these new rules in 2027 and 2030. So that again is just the DSNPs that have affiliated Medicaid MCOs offered by the same parent company in an overlapping service area. It sounds like what we're saying is that new members will be, the question asker says new members will be assigned to their respective MCOs DSNP, but for 2030, all members will be aligned with their DSNP. So Kat, I want to throw that to you here so that you can respond to that one. And I can also jump in and add to it as needed as well. And I think, Kat, your audio might be out again.
Can y'all hear me?
There you are. Hi, Kat.
I'm so sorry about that. So the new requirements that I discussed today go into effect over the next 5 years. In 2026, all special needs plans, including DSNPs, must complete an initial HRA for an enrollee within 90 days before or after the enrollment date. In addition, they must develop an individualized care plan within 90 days of conducting the HRA or 90 days after the enrollment effective date, whichever is. And then beginning in 2027, DSNPs that operate in overlapping service areas with Medicaid MCOs that are operated by the same parent organization may only offer one DSNP for the full benefit duly eligible individuals in the overlapping service area. There are 2 exceptions to this rule, which are summarized in slide 32. In addition, those DSNPs that have affiliated MCOs in overlapping service areas may only enroll new full benefit duly eligible individuals in 2027 if those individuals are enrolled in or are in the process of enrolling in the affiliated Medicaid MCO. Now, starting in 2030, these DSNPs will need to operate with exclusively aligned enrollment. The requirements for new enrollees in 2027 are aimed at helping the DSNPs get closer to having exclusively aligned enrollment over the next few years. And finally, starting in 2027, DSNPs that qualify as applicable integrated plans must issue integrated member ID cards for both Medicare and Medicaid benefits. They must also conduct integrated health risk assessments that include all required Medicare and Medicaid content.
Thanks, Kat. And just for some additional clarification on the question from the box, so it is true that the main difference between 2027 and 2030 is that the impact of the rule for 2027 is that DSNPs can only enroll new members if those people are also in the DSNP's affiliated MCO. So if someone contacts a DSNP in 2027 and the DSNP is affected by these new rules, that DSNP would have to check and make sure that that person is either already in their Medicaid MCO, or the DSNP would have to work with the state to set up a process by which the state would assign that person to the affiliated Medicaid MCO as part of enrolling in that DSNP. So the new people that get enrolled into these DSNPs in 2027 have to have this alignment with their Medicaid MCO. But if those DSNPs already have current members in 2027 who don't have that alignment, they can keep those people in the plan until 2030. In 2030, anybody who's in the plan would have to have that alignment between the DSNP and the Medicaid MCO. I also do just want to offer one clarification. CMS and states won't be automatically enrolling people who are in the Medicaid MCO into the DSNP. DSNP enrollment will still be voluntary. It's still a choice that people make. And it is possible to be in the Medicaid MCO, but not be in the DSNP in these new years in 2027 and 2030. The real key here is that if someone does want to voluntarily enroll in a DSNP, and it's a DSNP that is affected by these rules, that DSNP can only bring that new enrollee in if they're going to have this kind of alignment. And I do want to also acknowledge that ICRC and the CMS Medicare Medicaid Coordination Office are going to be doing individualized outreach with all of the states who have DSNPs that are affected by these new rules for 2027. So if you're a state and you think you might have DSNPs that might be affected by these rules, watch for an email from us. We're going to be reaching out to you to try to set up time to talk about this and to talk about how these rules play out in specific states. I think we've probably got time for maybe one more question here. Tita, why don't we go to one for you briefly before we wrap things up? From your section, I know I saw another one that came through. Here it is. It was, how do the supplemental benefits that are offered by DSNPs compare to the supplemental benefits that are offered by regular Medicare Advantage plans?
Oh, that's another great question. So like other Medicare Advantage plans, DSNPs can offer supplemental benefits, but because DSNPs only enroll duly eligible individuals, they can focus the supplemental benefits they offer on the particular needs of this population. So for example, because many duly eligible individuals receive a full array of medical benefits from Medicare and Medicaid, a DSNP may choose to offer more non-medical supplemental benefits, such as food and produce, non-medical transportation, or supports for caregivers, such as respite services. So it's also important to note that supplemental benefits offered by DSNPs may sometimes overlap with Medicaid coverage. And when that happens, DSNPs and states have to ensure that DSNP enrollees use the supplemental benefits first before the Medicaid benefit is used.
Thanks, Tita. So Emily, if we can go ahead and advance to the next slide, I'm going to go ahead and wrap things up. I just want to thank you all very much for participating in today's webinar, and thank you again to all of our presenters. If you'd like to revisit this conversation and the slides, we will be sharing a recording of the call and the slides again from the presentation, both with attendees in the coming days, and we will also be uploading them to the ICRC website as well. I'd urge you to visit that website at integratedcareresourcecenter.com to find links to past webinars, written technical assistance briefs. You can also submit requests for one-on-one technical assistance there. And we really hope that today has been valuable for all of you. If you were logged into the Zoom, you should see a survey link appear at the end of the webinar. Please respond to that survey to help us make changes to our future webinars and try to meet all of your needs as best as we can. We really appreciate your time. And we'll also be sending that survey out with the recording and the slides after the webinar, so you can respond that way as well. Thank you very much, and I hope you all have a good rest of your day.